So to provide some context before we start the presentations, most of you on the call today already know that your HIV prevention programs routinely collect a lot of program data and that this takes a fair amount of effort and staff time. And much of this data, it's data that's required to be collected by CDC or other stakeholders or funders. So, typically your sub-grantees are sending data to the health department, and then in turn you're putting that together at the health department level to send back to CDC. So this sort of traditional view of data management is that it's kind of a one-way street. But this one-way approach isn't necessarily helping communicate back to those working in the field the value of their work or highlighting potential opportunities for improvement. So a more modern approach is, that all of this hard-earned data doesn't have to kind of go into a data black hole once it's been reported up and never to be used again. Instead, a lot of the routine program data that health departments are collecting can also be reused internally for program improvements and to provide feedback to your partners in the community. So in addition to the basic data-related requirements, your data can and should work for the benefit of you and your programs. So data can help provide accountability for your programs. This means using data to help assure that your programs are high quality and that you're reaching the right people. In times of limited funding, good data can also help your program be more competitive for funding opportunities by telling the story of the work that you're doing in your jurisdictions. And then once you've obtained funding, program data can also help ensure that you're then allocating that funding to the right places. On the national level, there's an increased focus on data-based approaches to HIV prevention, for example, a big one being data to care. And things like data to care rely heavily on having quality data from both surveillance and program data. And so if you're working to implement a data to care program, for example, incorporating regular feedback loops about data quality can help ensure that your data is as accurate as possible. So, in sum, your data should work for you and not against you. When you're collecting all of this data, and once you have it, it can then be repackaged to help create feedback loops on the information that is most helpful to you and to your partners in the community. So rather than just being an administrative burden, data can really be a very helpful tool to help tell the story of how your programs are working to improve outcomes in your jurisdiction and what needs improvement. So with that in mind, we're now going to hear how 2 health departments are putting their data back to work. I'm going to turn it over now to Nicole to get us started talking about data quality assurance. So Nicole, you can press *7 to unmute your line.
Thank you, Erin. Can you hear me clearly?
Yes.
Great. Thank you for the introduction. As she said, I'm Nicole Collin-Valdivia, Iowa Department of Public Health, and I work in the HIV Prevention Program. And so I'm going to talk specifically about our data quality assurance process. So first I'm going to just provide a little bit of background on the HIV prevention landscape in Iowa. So our HIV prevention funding comes from the Centers for Disease Control and Prevention, and we have 10 contractors at this time which deliver HIV rapid testing. And I have a map here of where those are located within the state, and they are in our most populous counties, and they have the highest rates of HIV within Iowa. So our contractors actually conduct direct data entry into Evaluation Web, and they do administer risk assessments on all clients, including all those at both healthcare settings and non-healthcare settings. So we actually have our own instance of Evaluation Web through Luther Consulting, and we have integrated hepatitis into our Evaluation Web instance. And so that includes both hepatitis C testing and then A and B immunizations. So 9 out of 10 of our contractors who administer HIV testing also administer Hep C testing and immunizations. So, and as far as our numbers, we administer in 2015 there were almost 4,200 HIV tests administered, and the number of tests per contractor ranged from about 8 per month to around 90 per month. So there is quite a bit of variation there. So our data quality assurance process, which we sometimes just call the DQA process, Basically, it's our way of verifying, correcting, and maintaining our data set within Evaluation Web so that our data have high quality, because that helps to describe, as Erin talked briefly about, the activities that are happening, the populations that are being reached, and then the impact on HIV prevention within our state. And the quality of that data does influence decision making. So our data quality assurance process has been implemented since 2010, and we do revise it probably annually just to keep up with any changes in data variables, as well as just the needs of the state, how those are changing, and what information we need to know and what data we deem is most important as well. So there are several purposes to our data quality assurance process. One of the main purposes is really just to highlight any data errors and discrepancies within our data set. And we also want to highlight any records of both newly identified HIV positive clients and previous clients, because we want to make sure that the agencies are staying on top of following up with those referrals to care, partner services, HIV prevention services. We want those to stay on their radar to make sure that the clients are receiving referrals to care that they need. We also want the agency to be aware of progress toward meeting goals and objectives. And at the beginning of every year, when they respond to the request for application, they make an objective as far as how many HIV tests they anticipate administering for the upcoming year, and we want them to be aware of where they are in the progress toward meeting those objectives. We also want them to be aware of their positivity rate, and within our state's comprehensive plan, we have a goal of 50% of all HIV tests being administered to MSM. And so that's something that we monitor closely with our sites to let them know how they're doing with that. So we, again, with positivity rate, we want to help them understand what their positivity rate is. Our sites this year do receive an incentive for that, and so that's something that they're interested in knowing. And one thing that we also do is, along with ensuring that those linkages to care are occurring, or re-engagement in care for the positive clients, we do match data with the surveillance office as well, just to ensure that the quality of that those data are valid, really. So when we go through our data quality assurance process, there are 3 data sources that we're actually accessing. And first of all, it is within Evaluation Web, and so our contractors enter their data into Evaluation Web within approximately 72 hours of test administration. This is going to vary somewhat based on if they're doing outreach testing on a Friday night. It could maybe be a little bit after that, but so there's a little bit of flexibility there, but generally within 72 hours. So that's our first data source. The second data source is that based on their rapid testing logs that they keep, they complete their own quality assurance report, and they email that to us by the 10th of each month. So that's our second data source. Then our third data source is that our state hygienic lab, and that's the agency that conducts the confirmatory testing from our sites, they email a monthly report to us to tell us how many confirmatory tests they have administered. And so those 3 data sources are used. They're compared and analyzed, and we put those into an Excel spreadsheet and then email those to the agency each month. So this is actually an example of the template that is used to share data quality with our sites. And I think this is has been emailed out or will be emailed out, but we're very happy to share it with anyone who'd be interested. Each state may differ based on the amount of data sources they have. But again, so we have the rapid tests, which come from Evaluation Web, and then the agency's own quality assurance report. And then we have the conventional tests, and that report comes from both Evaluation Web, but also our state hygienic lab. So things to point out on here, we include the projected number of tests that they anticipated administering, the percent to goal, so what their progress is in meeting that. So the percent of HR/DIP, what that refers to is the percentage of testing that has occurred among high-risk and disproportionately impacted populations. And those are based on epidemiological data in Iowa as far as populations that are impacted by HIV. And so, for example, men who have sex with men, injecting drug users, or persons who inject drugs. Within Iowa, persons who are African American or Hispanic are disproportionately impacted by HIV, and so that's what this number is, or that percentage is capturing. Additionally, again, we have the percent of MSM listed on here because we want our agencies to be cognizant of the percentage of MSM that they're testing, and most our agencies, when they complete or respond to the request for application every year, they do come up with specific strategies to engage men who have sex with men within counseling and testing services. So we also have the positivity rate on here, and so as I said, we want our agencies to be aware of that. So then toward the bottom of the form, again, like I said, we highlight the records of cases that were identified as positive, both previous and new positives, for either the linkage, because primarily we're looking for the linkage to care, re-engagement and care, but also partner services and some of the other variables that CDC requires, like housing status. So as I said, our evaluation web system is actually integrated with HIV is integrated with hepatitis, and so our hepatitis coordinator and I actually work together on this. And so in the template that's emailed out, there are two tabs at the bottom, and one of those is for hepatitis C testing, and one of those is for A and B immunizations. And so those are actually also included in our data quality assurance process. And so the hepatitis coordinator completes those portions of the spreadsheet, and then I work on the HIV portion, and then we send it out. And so it goes out to it goes out to the agencies once a month. Each agency only receives their own; they do not receive other agencies' data, and we do include supervisors on that. And usually, I would recommend asking the agencies who they want on those emails, because it may not just be the people who actually administer testing may not be the same as those who enter data. And so if there are corrections to be made, the people who enter the data need to know about that as well. So, and then what we do is we just ask them to make any necessary changes within 2 weeks. And after since we've been doing this for several years now, the data issues and discrepancies tend to be lower, because agencies, when they're having to correct mistakes several times, tend to make that mistake fewer times in the future. So we don't have too many errors now, but if there are, we ask them to correct them within a couple weeks or so. So this is just an example of email language that's used, and basically we just tell them the dates of which the report is covering. Usually at the end of the year, we also just send out the final report, and then sometimes it's just a summary of the data across the state. And again, like I said, I would recommend asking supervisors specifically who they want to receive this email, because it could certainly vary by agency from what we have found. So just other methods that we've used for improving data quality within our evaluation web system. In-person trainings. This is kind of per the request of the agency, and especially with new staff, I do think this is helpful, because the agency may have a way of entering data that may work for them, but there could be certain variables that they're glossing over, or certain aspects of data entry that they may not think of as important as perhaps should be. And so I think sometimes with new staff especially, or if there are, we've had agencies that they've had a person or two who's really struggled with data entry and has had numerous errors, and so I think it's helpful even to maybe pull that person into a training to just refresh them on data entry and running reports and how that should look. I also did create a counseling, testing, and referral guide for our agencies that's specific to our instance of Evaluation Web, and so I do have screenshots of data entry. We do make minor changes to our system every year. Since we have our own instance, we're able to do that. And so I do have to update that quite often, but it does give them an idea, especially if I'm not able to meet with them or if they just have a quick question, they can look in there and it will show them specifically how data need to be entered, as well as running reports too. And in there's a guide to improving data quality, and it's specific to both the collection of the data but also just entry of the data. And then there's a guide in there just on some data errors. And so there's a small little screenshot here of a chart that includes some common errors that they may encounter when entering data or trying to run reports. And so it just tells them why it's a problem and how to fix it. And there's also then just a guide on troubleshooting an evaluation web. So again, if they're getting error messages, it provides them with information on how to remedy that. So another way that we improve data quality is through site visits, and we do conduct site visits annually with all of our agencies. And at that time, we do talk about if there are any issues with data collection or entry, if there's any problems with data quality. So we also ask for any feedback they have on, whether they find the data quality assurance emails helpful, and we have found that they do. But also just talking about any improvements or anything that we can help them with. So overall, the feedback from our contractors has been very positive. And as far as outcomes from implementing our data quality assurance process, overall our data errors have really decreased. And again, I think part of that is that when they're having to fix these things themselves rather than me going in and fixing them, they learn why it's an issue and they tend to, when they're entering data the next time, get it right that time. And so that's certainly been an improvement. Overall data quality has improved, and every state gets their data quality feedback reports, and we rarely have any problems with data quality in there, and so that has been helpful. I think part of it also is just that the follow-up for our clients who are identified as HIV positive is being monitored more closely, and so agencies are staying on top of making sure that those clients, whether they are previous or newly identified clients, are being linked to care and partner services. So as far as feedback from our actual agencies, they've said that they appreciate having the feedback and being able to quickly correct it. Waiting until the very end of the calendar year and trying to fix 12 months of data errors would be quite cumbersome, but having this opportunity monthly means that it may take them, if they don't have any errors, it would take them no time at all. If they do, it would probably take less than 5 minutes compared to waiting till the end of the year. So, also, if you wait till the end of the year and you're trying to remember a case from January, it's going to be hard to remember much about the situation, and so it's easier for everyone to take care of it in a timely manner. Supervisors have said that they appreciate being able to just monitor their progress toward meeting goals and objectives, and so, as I said, there is an incentive for achieving a positivity rate, a certain positivity rate, and so they like being able to just look at the reports every month and see how they're doing as far as the number of tests they've administered and their positivity rate and linkage to care. And by us doing the data quality process, it takes it off their plate. So that's one less thing for them to have to worry about as well. So a few lessons learned or tips that I could offer is, I think one thing is make sure that they understand that the purpose of it is not punitive and that it really is to just improve data quality and to help them as well. And there are agencies that will sometimes panic if they get the report and there are errors, and so having to reinforce that it's really not, it's not big of a deal, it can be fixed. And so, but we just want to make sure that our data quality are high. As I already mentioned, make sure you ask the agency who should receive the emailed report. Like I said, if it's an administrative assistant who does data entry, he or she may not do any testing, they may not really even know a lot about the program, but if that's the person who's going into Evaluation Web and entering all of the data, they should probably be included on the reports so that they're the ones who can go in and make any changes that need to be made. Another thing I think is helpful is to create canned reports and evaluation web, because then agencies can do their own checking of data. And we found that a lot of them actually do, and sometimes I'll even get calls for them to help make a custom report for them if they want to look at data in maybe a little bit different way than we do, or they're more interested in other aspects of it. And so I think that that's helpful, that they can do some of their own. So then they can catch any issues before I do as well. I think it's also important to include praise and make sure that, especially if there are a lot of data issues, make sure that they are aware of what they're doing well. So we are a low incidence state, and so having 10 contractors makes it easier for us to monitor some of this than other states. And so potential options for improving data quality, maybe just to focus on follow-up for clients who are identified as living with HIV, or maybe doing the data quality assurance checks every 2 months instead of monthly, or kind of spot checking. Depending on the sources of data that a state has, they may not look at all 3 sources of data like we do. So the evaluation web, the rapid testing log, QA report, and then the lab data, they may just focus on evaluation web. So it would just depend. And then another option would just be to create those canned quality assurance reports with an evaluation web, and then if the agencies can assign their own person to do that, they can run reports and make any corrections that need to be made. And there can certainly be guidance that can be created to help them with this. All right. I do have my contact information on here, so you're certainly welcome to contact me with any questions. I did see a question came through about the number of HIV tests that we administered, and in 2015 it was about 4,200.
Great, thank you, Nicole. And just a quick reminder, if other folks on the call have questions, you can type them into the chat box on your screen, and we will get to them after Virginia's presentation. I also just wanted to note, we did send out Nicole's data quality assurance template with the webinar reminder, so you do have access to that resource if you pre-registered for the webinar. And with that, I will go ahead and turn it over to Fatima and Virginia. Fatima, you can press *7 to unmute your line.
Okay. Good afternoon, everyone. Again, my name is Fatima, and I'm really pleased to be presenting on some of Virginia's efforts and really the collective efforts of the HIV testing team. So my presentation is really going to focus on the different ways that in Virginia we've used data to help enhance our community HIV prevention programs, particularly our community HIV testing program, and especially in terms of targeted HIV testing. So there really are a number of ways that we are communicating data with our community-based organizations, and I'm going to go through each one in a little bit more detail, but just general overview, we produce routine HIV testing data reports that we share with our CBOs each year. Additionally, we've recently done an HIV testing yield analysis that really focused on increasing testing among men. We are working on helping our CBOs get access to Evaluation Web for the purpose of running reports, and we're also providing training on Evaluation Web. And unlike Iowa, all of our HIV testing data is entered by our central office staff. And lastly, I'll share just a few comments about how we're using the NASDAQ Yield Analysis Toolkit, which was released in the summer. So the HIV testing reports, and I'm going to have examples. What they are, they're individualized reports that we prepare for each of our funded agencies. And what we're really trying to do is we're presenting data in a way that allows our agencies to compare their actual attainment to their program targets, so that at the end of the year or a reporting cycle, our agencies can look back and see to what extent they met their objectives. They also work to assess each agency's reach to the highest risk populations. And they also compare HIV testing efforts of each agency by regional as well as local HIV epidemics. And they really do work well to enhance the communication between staff at all levels of management. So when we send these out, we encourage each agency to get together with their program staff, their management staff, and to really go through the data reports and to think collectively on, what areas need improvement, but also to highlight, their strengths and areas of success. So the reports we break down by race, ethnicity, gender, risk category, and we also outline and we share HIV, overall HIV testing numbers as well as linkage to care. So this is just an example of one of the pieces that we share. So this is for one of our agencies who provides HIV testing in the Crater Health District. So what we have on the left is the HIV epidemic among men and women in the Crater Health District. And so what you see is that about 3/4 of all people who are living with HIV in that area are men, and just a little under 1/4 are females. And so then we compare that with the agency's HIV testing efforts for just a particular program, so that you have it's really easy to compare those two, and it's pretty striking when you look at the 76% of men that are living with HIV/AIDS in the region compared to the 43% of men who have been tested. And we also include testing numbers so that it's easy to see of the 43% of men that were tested, 100%, that 100% of the tests were positive tests for men. So this is similar, but for race and ethnicity of a different contractor. So on the left, we have the combined race and ethnicity of people who are living with HIV/AIDS and the health in that region. And you see that 45% of folks who are living with HIV/AIDS are Black. And then it's really easy to compare it to the 29% of non-Hispanic Black clients that have been served by Nova Salud in that area. And then also the 34% of white individuals who are living with HIV/AIDS compared to 25% of individuals tested. And when we share these reports, we usually will include a few sentences. So in addition to the data and the charts, there's some context. So for this particular program, the CAPAS program, reaching Blacks and Latinos is really the goal of the project. So although they're reaching more Latinos than there are living with HIV/AIDS in the area, we still do encourage that. So this next slide looks at risk category, and this is probably one of the most striking slides that I've shared with folks. And so in the Southwest Health region of Virginia, MSM make up 43% of all people who are living with HIV/AIDS, and for CCS, who provides services in that area, only 6% of their total tests can be attributed to men who have sex with men. So it's a pretty strong visual, and when we've shared that with the contractors, we've actually been with them in a meeting, and it really got folks talking and thinking of strategies and not. This was probably the first time that many of the program staff even realized this. So the next thing that I'm going to talk about is the yield analysis that we've done to try to encourage increased testing among men. So what it is really a yield analysis that focuses on the different epidemics among men and women. And when we started doing this, we really wanted to present this in a profound way that's new and easy to understand, so that people could really understand the importance of reaching more men. And in addition to that, we also included a cost analysis just in an additional attempt to further guide outreach efforts. So I'm going to go through the analysis. So the first question that we asked, just to kind of set the framework for this when we presented this at a contractors meeting with, in the fall with many of our contractors, was we just wanted to start by looking at the HIV epidemic in Virginia among men and women. So this is just to provide some context. So about 3/4 of all people who are living with HIV/AIDS in Virginia are males, 26% are females. And then we looked at men. So of all men that are living with HIV/AIDS, how many of them are MSM? And so what we showed was 63%. So then the next question was, well, what does HIV testing look like for all of Virginia's sponsored programs? So this includes our Category A, our Category B, as well as our CAPAS testing. And this is testing at CBOs, health departments, STD clinics, CSBs, so really all of our testing sites. So in 2014, we've done a little over 78,000 total tests, and of those tests, 57% were female and 42% were male, and less than 0.5% for transgendered male to female individuals. And this chart is just like a percent of a whole, a proportion of the whole. And so this next slide is just the positives. So out of those 78,000 tests, there were a total of 229 positives, and out of those positives, 15% were female, and the vast majority, or 84%, were male, and just a little over 1.3% were transgendered male to female. So this is just those two graphs together. So on the left here, what you're looking at are the total tests that were administered. And on the right, these are the total number of positives that were identified. So this really proved to be a strong visual for understanding the importance of reaching more men. So when we looked at all of our tests in Virginia, the next question that we asked was, well, how many individuals did we have to test? So how many women had to be tested before you identified one positive woman? And similarly for men and transgendered male to female. So we calculated that a little over 1,300 women had to be tested before identifying just one positive. And a significantly smaller number of men, 172, needed to be tested before identifying one positive, and 52 transgendered male to female individuals had to be tested before identifying one positive. So what I just shared was for all of Virginia's programs, and so what we looked at next was just our community-based organizations that are providing targeted testing or that have the capability to provide. Sorry, I've gone back. HIV testing. So we have about 13 CBOs that provide HIV testing, and in 2014, there was a total of about 16,000 total tests with 76 new positives. And again, this includes Category A, Category B, and CAPAS testing, but only for our community providers. So a similar graph as to what I showed earlier. In 2014, you see that 44% of all individuals that were tested were female and 55% were male. So we then compared that with the data for positives, and 84% of all positives were men and 14% were women, and just a little over 1% were transgender male to female. And this is closer to what our state outcomes were. So again, the next question that we asked was, how many individuals did all of our CBOs collectively have to test before identifying one positive? And so what we calculated that was to identify one positive female, our CBOs had to test 635 women. And to identify one male, they had to test a total of 137. And for male to female transgendered, it's 52. So I've just got a couple of examples that we shared. So this is for one agency that administered over 2,500 tests in 1 year. And we just, on the left, you have the data for their total tests, which shows 33% of their tests were to female and 63% were to males. And then on the right is the breakdown of their positives. So out of all of their positives, 15 out of the 16 were men. So this shows a number of things that, one, increased testing, so the higher volume of testing will yield more positives, but also testing more men will yield more positives, and particularly more positive men. So our second example was looking at a CBO that provided about 1,100 tests, and of their total tests, 51% were female and 49% were male. And their positive breakdown is all three of their positives were men. And when we shared all of this data, we provided each agency with similar charts, so that as we presented this, they could see how their agency stood as we went through the presentation. So we wanted to find another way to kind of guide outreach efforts. So why not money? So we calculated that to identify one positive female, our CBOs had to, or spent a total of $61,000 before identifying one positive, and a little over $13,000 to identify one male positive. So that's a pretty huge difference. And the way we calculated this was we added up the contract amounts, we estimated the amount of money that we used on testing supplies as well as testing kits, and broke that up in proportion to the number of positives. So this was like a really shocking figures. So the next question that we often get is, well, what about the women? And we have a lot of agencies that strive to serve women, and the message of increasing testing among men sometimes may seem like neglects the women, which is not the case. So we tried to answer that by sharing a recent HIV cluster of an HIV cluster. So what happened here was we had one gentleman who presented at a testing site for an HIV test, who then named another male partner who came in for an HIV test, and that gentleman was also identified as being positive. And what this really shows is from this one person is that we identified 5 women who were at very high risk of HIV or were infected with HIV. So the message around this is testing more men will ultimately help us identify women who would be at high risk for HIV. And also create the opportunity for making referrals for partner services, for emphasizing the importance of treatment as prevention, and encouraging people to get PrEP. So we wrapped up our session by kind of reflecting and asking ourselves, well, what does all of this mean? And the biggest takeaway that we shared was testing more MSM will yield more positive. Testing more men in general will help us identify more positives. And that there's also a real need for creative strategies for HIV testing and outreach efforts. But none of this means stop testing women. It's just a way to test more people that are at higher risk. So since we enter all of our evaluation web at our central office, one of the ways that we're helping our CBOs gain more ownership of their HIV testing data is by granting them access to evaluation web to run reports. And it's also serving as an additional way that our agencies can check their HIV testing data with what we've received in terms of their forms and what we've entered. So it's an extra quality assurance measure that really helps to facilitate communication, back and forth communication with our CBOs and our data teams. And it gives CBOs the power and the ability to generate reports that they may need for grant applications, as well as reports that they can use to share with their community partners. And ultimately, it also does help to reduce the number of data requests that are received by BDV. And lastly, after the release of the NASDAQ Yield Analysis Toolkit in the summer, what we did in-house was we got together with our HIV data, our HIV testing, and our M&E data team members, and we really tried hard to brainstorm and to think of ways that we can customize the NASDAQ toolkit for Virginia contractors. And this is still a work in progress for us, but ultimately it will be an additional resource that's available for our community-based providers to use data and to understand their data and to guide their HIV prevention programs. And that's the end of the presentation. I believe that the reminder that Erin sent out did include some templates that we've shared. Other members of the team that can be contacted are Ashley Yoakum and Heather Bronson, and we've all worked together on all of this. Thanks, everyone.
Great. Thank you so much, Fatima. And Nicole, thank you to you as well. That brings us to the end of our presentations this afternoon. So we have the remainder of the time, about 10 or 15 minutes, for audience questions. We did have some questions that came in over the chat box, but I wanted to first see if there's anyone on the call who'd like to ask a question over the phone. So if you have an audio question, you can press *7 to unmute your line. We would ask that you first identify yourself and then let us know which presenter you are addressing your question to. So do we have any audio questions?
Hey, this is Daniel from Vermont. Thank you both for your compelling presentations and using data, especially on an important service. I'm sorry if I missed this, but Virginia, how did you calculate exactly how many MSM you needed to test in order to find a positive?
So the calculation was how many men needed to be tested before identifying a positive, and what I did was I divided the total number of tests by the number of men that tested positive.
Ah.
And then I did the same for the women, as well as the transgendered male to female individuals.
Brilliant. Thank you much.
You're very welcome.
Great. Do we have any other audio questions? You can press *7 to unmute your line. Maybe while we're waiting, we can start taking some of the chat questions. So here's a question for Nicole. Someone wanted to know a bit more about your testing sites in Iowa. So specifically, are they mostly clinical, or are they also community-based testing sites?
Hi, are you able to hear me?
Yes.
Okay. They are actually, so the 10 sites that we have, 8 of them are local health departments that are STD clinics, and then 2 of them are federally qualified health centers. And so they're all considered healthcare settings, but so considered, I guess, clinical, but the majority of them also do community-based outreach testing. So hopefully that answers your question.
Great, thank you. Question for Fatima. What format are the yearly routine reports presented in? I think she's talking about the first set where you were comparing population characteristics to the testing population. So I think the risk and gender and race ethnic group charts. Correct me if I'm misinterpreting your chat question. Could you talk about what format those reports are sent back to the contractors?
So the reports are sent electronically as a PDF document of about 3 to 4 pages, and it's predominantly the graphs. It includes about a paragraph describing how the data was pulled and how it's compiled, and just a few sentences that describe what it is that you're about to review. And in between the charts, for some of the sites, depending on how the data looks, we do insert some comments and some feedback, but it's shared electronically as a PDF.
Great, thank you. Do we have any other phone questions before I continue with the chat questions? Again, you can press *7 to unmute your line.
Can you hear me?
Yes.
Okay. I'm calling from the U.S. Virgin Islands, and I'm just very interested in the delivery that was given with respect to Virginia, because I lived in that area, and I just wondered if the data that was presented did a breakdown as to race in terms of how many blacks, males, were tested before one positive showed up for that particular group, and black females.
So internally, we did look at that, and we considered sharing that with our providers, but we really just wanted to focus on increasing testing among men as a whole. But that is something that we did look at, but decided not to share just because we wanted to have the general emphasis on increasing testing among men across the board.
I see. So on the percentage of men that were tested, how many did you say were tested before one positive showed up?
For our state testing, which includes all of our PDH-sponsored programs, our clinical or non-clinical saves, it was a little over 1,300 tests, and that's for about out of 78,000 tests. And for just our community providers, they collectively had to test 635 men before identifying one positive.
Okay.
One positive individual who is a man or male.
Okay.
Did that answer that?
Yeah, definitely. I know you mentioned it before, but down in the Virgin Islands here, I'm getting a little breakup from time to time, but I just had to react to a question because I heard you kind of talk about that. The first person that made a delivery from Iowa, I think there was 4,200 tests that were done in 2015, and that individual had explained that they also did something with Hep C in terms of evaluations in Hep C immunization. Could you tell me of those individuals that evaluations were done on for Hep C? What was the amount of persons that were tested and what that percentage showed?
Sure, I can try. Our hepatitis coordinator actually works more with our hepatitis data than I do. So are you wondering specifically about positives for hepatitis C?
Yes.
Okay, so, and I believe our positivity rate for Hep C testing was right around 10%.
Okay.
And I think it's fluctuated between about 10 and 12% over the last few years.
And this was 10% of the entire 200 tests?
So for hepatitis C testing, there were about 460 tests administered. In 2014, I'm not sure of final data for 2015, but usually we have anywhere between 400 and 500 Hep C tests administered per year with around a 10% positivity rate.
Oh, I see. Okay. Well, I'm Ian Douglas, a pharmacist practicing in the Virgin Islands, certified in HIV, and I just wanted to thank you guys for putting this on and allowing us to have access to the questions. Thank you.
Sure, you're very welcome.
Great, yeah, and thank you for your questions. We have another chat question for Nicole. This person was wondering if you could just talk a bit more about the section on your data quality assurance report where it says data errors. They were just wondering what that would indicate.
Sure, I went ahead and pulled that slide up again. And so that was actually a column that I had added at the beginning of last year. And so you can, let me see if I can pull my pointer up here. So in the notes column, it's usually where I identify any data discrepancy issues or include praise about, something. And so what I was finding is that sometimes if there was a specific issue, it was getting lost. And so what I would do is just, write yes or no in that column. But also what was happening is that I don't like to, when we move on to the next month, I don't like to delete the problem, any issues from last month, because I kind of like to keep a running log of those. And so what I had been doing is using the strikeout feature. So for example, if they had issues, a couple data issues in January, they corrected them, I would use the strikeout feature to cross them off. Well, for some agencies, for whatever reason, that didn't show up on their computers, and I'm not sure what happened there, but it made it look to them like they had, like I was indicating they had never corrected those issues. And so then what I would do in this data errors column is just write corrected, so they knew for sure that issues from previous months had been corrected. That's kind of a long answer, but that's basically the purpose of it. If it's helpful or not, I don't know. I think it at least prevents any problems from getting lost in other feedback that's included in the notes section.
Great, thanks for giving some more information about that piece. I think we have one final chat question. This is for you, Fatima, and it's sort of about outcomes of this data work that you've been doing. Has Virginia seen a shift in CBO's reach of testing men since presenting the data to them that you shared today?
So our yield analysis was shared in September, and we had planned to reassess that in about 6 months from that point to give folks enough time to create whatever need is necessary for them to retarget their efforts. But as for the data reports, in comparing this year's to last year's, I have certainly seen changes in a shift in the number of, for example, blacks that are reached and the number of MSM that are tested. So there are increases, but it's hard at this point to say from the yield analysis how much of an impact it has had since it's been shared just not too long ago.
Great, thank you, Fatima. So I think that this brings us to the end of our time today. So I want to give a huge thank you to Fatima and Nicole for sharing their work with us. And if you have any further questions for NASAD, you can feel free to contact me. My email address is on the screen now. And I will, again, just remind you that a recording of the webinar will be available to access on NASAD's website shortly. Just a final note that when the webinar concludes, you should have a brief survey that will pop up, and we would appreciate you taking the time to provide your feedback about the webinar to help us improve our future work. So huge thanks again to our presenters and for those of you who joined us in the audience today, and I hope that you have a great afternoon.